Okay, so we're just preparing the drapes here. We did a bit of landmarking of the chest prior to make sure that we would set up the drapes appropriately, so the area has been prepped. Now we're just draping here. So the next step, making sure it's as clean as possible at our insertion site. You can smoothen out the drapes too. Excellent. So we prepped our site. This is our standard procedure in the ICU. We make sure that the whole area is prepped. Now we're going to prepare the ultrasound probe in this sterile cover to introduce it into the surgical field here, or the procedural field. So I'm going to help you prepare the probe. Okay, you got it there safely. Perfect. Excellent. Okay, now just pull that sheath over and place the elastics on the probe. Just to keep the sheath in place. So I generally do prepare the ultrasound probe in this kind of procedure because it really helps to make sure that you're in the correct place when you're doing the procedure. And generally what we're going to do here is we're going to landmark the site in advance of the procedure with ultrasound to make sure we're above the diaphragm. So let's see a clear diaphragm here. Okay, nice. You can see here kind of semilunar. There's the spine sign, the nice anechoic field. Okay, helps determine that we are indeed in a safe place and we're well above a diaphragm. Now, we're going to try this in two planes. So I'd like you to move the probe 90 degrees counterclockwise. And we can see here a very large area in cross section, very nice space to enter and safe. We're away from lung and a very good distance, usually for more than 3 centimeters, but here we have plenty of distance to work with. But now that we've marked it in two orthogonal planes, now we're going to use a blunt field cannula to make a mark on the skin. That way it'll help guide your thoracentesis. And here we are doing ultrasound guidance, but this is called static guidance, where we've made a mark in advance of the procedure versus dynamic guidance where we're going to watch the needle go in. I generally will advocate for static guidance as I do believe it is safe and appropriate for most skilled practitioners to perform. So now we're going to freeze the area, and we'll freeze the skin first, then move into the periosteum, and then once that has had adequate time to settle, we'll introduce a large needle, usually around 22 gauge, 1.5 inch, all the way down over the rib into the pleural space to make sure we have a satisfactory tract that has been infiltrated with local anesthetic. So that's great. We've got a clear tract all the way down to the pleural space. Okay, now for the next step, small incision, usually about really a 1/4 inch or less, just to the skin. That way you can pass the catheter and needle assembly over. Now next, I want you to hold up the catheter needle assembly and just show me your approach here. Okay, so the catheter's up top and the needle's behind. Okay, we'll attach a syringe to the back. I think there's. Now how this device works is you enter on block, and once you enter into the pleural space, you successfully aspirate pleural fluid. You'll go a tiny bit further, and then you'll advance the catheter while the hand holding the needle and the scalpel will remain in place. Exactly. So that'll pass above. Into the pleural space while the backhand remains stable. This just ensures you're not introducing the whole assembly with needle into the pleural space. So now that we've made incision in our area, we know exactly where to go. We're going to aim for the rib, and then we're going to pass the needle, pass the device towards the rib and then above the rib. So we're going to advance it, and then we're going to remove it from the posterior part of the catheter itself. So now we're going to advance through, aiming for the rib, and then passing over the rib.
So I feel the rib.
And we're going to start, as soon as we'll start aspirating as well to make sure that we'll get fluid back. Okay, now make sure here you're going to aspirate as you pass. Okay, and once you're in the pleural space, the catheter can be advanced. There you go. Perfect, you have pleural fluid now. Okay, now the catheter can be advanced, and that right hand can remain fixed. There you go. Okay, now needle comes out, and now it is safely in place to collect a sample or to connect to a chest tube. You can also leave that rear assembly in place, which would allow you to have a stopcock attached to it. So there you go, there's a sample, and this can either be stitched in place, or it's going to be left in temporarily to get a sample for further testing.